Good morning, good afternoon, good evening, everyone. It's an honor to welcome you to this important session on advancing care of neuroblastoma patients. So neuroblastoma, as we all know, it is the most common extracranial childhood tumor, and the treatment of neuroblastoma is an enigma. Why it is enigma? Because we know that neuroblastoma, some of the neuroblastoma, which are low-risk neuroblastoma, they are highly curable, highly treatable, and there are high-risk neuroblastoma where we do everything, but we are not able to get that kind of a cure. So today we are going to have a very good session. One is that we are going to talk about the DFMO in the advancing neuroblastoma care. And then we have a very good panel discussion to know about the various issues which we want to discuss about neuroblastoma care, which includes ALK inhibitors, haplotransplants, immunotherapy, and role of MIBG. So for the panel discussion, we have Dr. Manas Kalra from Gangaram Hospital, Delhi, and Dr. Vinita from RCC Trivandrum, and Dr. Shivani Patel from Choithram Hospital. And now I would like to welcome Dr. Giselle Scholler, who is the guest speaker for today's session. She is a Division Chief of Pediatric Hemato-Oncology BMT at Penn State Health Children's Hospital in Pennsylvania, United States. And as you can see in this picture, it speaks a lot about her. She wants to change the outcomes of neuroblastoma, which is a deadly disease. She has been a chair of Beat Childhood Cancer Consortium. She founded the Beat Childhood Cancer Consortium in 2010, and she has opened almost more than 18 phase 1 and phase 2 clinical trials, that too in pediatric cancer. The Beat Childhood Cancer Consortium is now a team of more than 40 universities and hospitals across US, Canada, and Lebanon that together offer a network of clinical trials, and they are doing tremendous work in these deadly conditions. Her lab work focuses on the study of DFMO, targeting cancer stem cells in neuroblastoma and the brain tumors. So today we are really privileged to have Dr. Giselle Scholler with us, who has made remarkable contributions in neuroblastoma care and research. Dr. Giselle, a very warm welcome, and we are eager to hear from you. Thank you so much.
Thank you so much, Dr. Bansal. I'm going to just my screen quickly. And I think that's going to work. Can you see my slides?
Yes.
That's wonderful. Thank you, Dr. Bansal, for that wonderful introduction. It's such an honor to be here, and I'm thrilled to be able to share some of the work that our team has done in neuroblastoma, specifically focused on DFMO. Move the picture so okay. Just in terms of conflict of interest, I'm a speaker for US World Meds and YMAMS. And as Dr. Bansal mentioned, neuroblastoma is the most common non-brain tumor, solid tumor in children, occurring in children generally less than 15 years of age, 1 in 7,000, with two really interesting peak incidents occurring, one less than a year, generally our infant neuroblastoma, and the other peak occurring at about 3 years of age, our childhood neuroblastoma. And these are defined by risk categories. As you can see from the graph on the left here, low risk and intermediate risk neuroblastomas generally have a very good outcome, often with just observation, surgery, or minimal chemotherapy or moderate chemotherapy. These patients have a very good outcome, whereas our high risk neuroblastoma patients, which are the children closer to with a peak at 3 years of age, are high risk and have a very poor prognosis. And this is the group of patients that we've chosen to study. Our high risk neuroblastoma therapy generally lasts about 18 months, consisting of induction with chemotherapy and surgical resection, consolidation here with high dose chemotherapy or autologous stem cell transplant. Still in the United States, it's divided between tandem transplant versus single bone marrow transplant, but one or the other, and then radiation therapy, and then followed by immunotherapy with an anti-GD2 antibody with cis-RA. And this has become the standard of care really since the COG landmark study AMBL0032 that showed an increase in event-free survival with immunotherapy added to the end of post radiation. And you can see from the start of immunotherapy to the end of immunotherapy, there are still patients, about 14% of patients that do relapse during immunotherapy. And while this is a significant improvement in event-free survival, it's still not enough. We're still seeing close to 50% of our patients relapse. And this is kind of our biggest problem in high-risk neuroblastoma, is that, as Dr. Mansell mentioned, these are responsive to chemotherapy, to irradiation surgery. We can get children into remission, but relapse is the major problem, with over 30% of patients relapsing within just 2 years, closer to 50% when we go out to 5 years. Most relapse patients then do die within 5 years of that relapse. And so DFMO was investigated to focus on relapse prevention. So just a look at why do cancers relapse. So cancer stem cells are thought to be a relatively refractory part of the cancer, relatively refractory to chemotherapy and radiation therapy, because they are the more quiescent cell. So if we look on the left, the tumor cell is made up of it's heterogeneous, and there are many rapidly dividing cells. The red cell represents the cancer stem cell, with rapidly dividing cells that are responsive to chemotherapy and radiation, and the tumor shrinks. But if the stem cell remains, it can at some point cause the relapse and recapitulate the entire tumor. They are highly tumorigenic and can form the tumors. And whereas if we look at the bottom, if we're able to target that cancer stem cells, tumors can actually regress and go away on their own. And so we wanted to look at what can target that cancer stem cell. When we looked in the literature, the Lin28 LET7 pathway is a cancer pathway that really regulates stem cell self-renewers. Tumors that have high Lin28 on the right have high glycolytic metabolism, overgrowth, and oncogenesis, or can cause cancer. Versus when the Lin28 goes down and the LET7 goes up, we see tumor suppression, differentiation. Neuroblastoma cells are very high in Lin28. Lin28 is a poor prognostic factor. When we looked at the Kaplan-Meier curves of patients with high Lin28 neuroblastoma have a very poor prognosis. So DFMO is a medication, a drug that targets ornithine decarboxylase. It's a rate-limiting step in polyamine synthesis. Downstream of polyamine synthesis is the Lin28 LET7 pathway. And so inhibition of DFMO inhibition of ornithine decarboxylase was postulated to suppress Lin28, thereby increasing LET7 because it is an axis. LET7 also can suppress MYC-N, another important gene in neuroblastoma. And so we looked at this in the laboratory, studying DFMO, treating both BE2C, SMS, KCNR neuroblastoma cell lines for 48 or 72 hours with DFMO at increasing doses, and we're able to see that we do see an inhibition of ODC, which is the gene target for DFMO. We also see a significant decrease in Lin28 as well as MYC-N, as well as other cancer stem cell markers. SOX2, NANOG, and CXCR4 are cancer stem cell markers. So we're seeing the Lin28 go down, MYC-N is suppressed, as well as all of the cancer stem cell markers are suppressed in the presence of DFMO, suggesting that DFMO may be able to target the cancer stem cells. We also, if we're able to target that, we would postulate that then the neuroblastoma cells would undergo senescence. And so using a beta-galactosidase assay, which is a marker for senescence, we saw in 5 different neuroblastoma cell lines at both 48 and 72 hours that when we treat with DFMO, the cells undergo senescence and stop dividing. And then furthermore, we looked in neurosphere assays. So in a 96-well plate, plating 1 or 2 cells per well, looking to see if that cell is a cancer stem cell, it would be able to recapitulate a tumor and form a neurosphere. When what we see in general, between 20 and 40% of the wells are able to form neurospheres in these 5 different neuroblastoma cell lines. But with increasing doses of DFMO going from the red to the blue to the yellow to the green, we see that the neurosphere formation is inhibited in all of the different neuroblastoma cell lines, and we monitor these over 4 weeks, and it stays consistent over 4 weeks that the neurospheres in the presence of DFMO, the neuroblastoma cells are not able to form neurospheres to the same extent as without the DFMO. And so kind of putting that together, DFMO inhibits ornithine decarboxylase, which decreases polyamines and restores the Lin28-Let7 balance by decreasing Lin28, increasing Let7, and then leading to G1 cell cycle arrest and senescence, as well as suppression of neurosphere formation, suggesting that DFMO's effect on neuroblastoma is a cytostatic effect. Historically, in papers prior to our research, studies looked at DFMO as being a cytotoxic agent, but requiring much higher doses in the millimolar doses to be cytotoxic. Those are not physiologically possible in a patient. So our research was really done at physiological levels based on PK analysis. So the doses that we're able to achieve in a patient, these are the results that we're able to see in the lab. So it's really more of a cytostatic effect. We also looked in our mouse models, and one of the things that suppressing the cancer stem cells, as according to that Lin28-Let7 table that I showed before, should also decrease glycolytic activity. And so when we monitor in our in PET scans in our mouse, and we were able to show that the mice treated with DFMO had decreased glycolytic activity compared to the mouse without DFMO based on PET scan activity. And interesting, one of our responders in our phase 1 study as well, because their MIBG was not, their neuroblastoma was not MIBG avid, and so we follow the patient with PET. After one cycle of DFMO alone, this patient's neuroblastoma became PET negative, correlating with what we had seen in the animal models as well as correlating with the fact that the Lin28-Let7 pathway was being affected in this patient. So our first phase 1 study, was really done with patients with active disease. And so although really our goal was to prevent relapse for us in the United States, phase 1 needs to be in patients who are relapsed refractory patients with no curative option, as we evaluate the drug for safety. And so we were able to look at 4 different dose levels in our phase 1 study, 500 to 1500 milligrams per meter squared orally twice a day. Patients were given DFMO in cycle 1 by itself to monitor for this safety of the medication by itself. And then we're given 5 cycles with DFMO and low dose oral etoposide, because again, these were patients with active disease. By just the etoposide 50 milligrams per meter squared daily for 14 days, starting in cycle 2. And then if after those 5 cycles, the patients were doing well, they could continue on DFMO alone. All patients were found to be safe. All the doses were found to be safe with no dose limiting toxicities. We did not reach an MTD, but we were at a therapeutic dose, and so did not feel like we wanted to continue increasing the dose further. What was really interesting, out of 16 patients on the phase 1, who were initially told that they were incurable, their tumors all became glycolytically active, and then as per the cancer stem cell theory, that if you are able to target the cancer stem cell, the tumors will regress on their own. This is what we were able to see in these patients. They're all completed to, the first patient on the right was our first patient to do well, which we did not expect from a phase 1 study. These are the really only 3 cured patients that we've had from a phase 1 trial. He was treated for 2.5 years because we didn't know when to stop. And then we decided 2 years was going to be the time point. And so the other 2 went on to 2 years. We stopped treatment. All of them, it's been over 10 years, are continuing. The 2 boys are in college right now, and the girl is in high school and doing very well, has not received any further treatment after stopping DFMO. So this was really exciting, but we wanted to look at the ability to prevent relapse. And so we did 2 mice models. The first one where we pre-treated DFMO cells with, pre-treated neuroblastoma cells with DFMO for either 10 or 20 days to, in culture, remove the cancer stem cells, essentially. And then we did limiting dilution assays where we treated mice, groups of 10, with either 10 cells, 50 cells, or 100 cells, so minimal disease, kind of recapitulating minimal residual disease. And we see that the group, and with 2 different mouse models, the BA2C and SMSR, and what we're able to see is that the cells treated without DFMO were able to form tumors in the mice, whereas especially those treated for 20 days prior to injection, then the live cells were injected into the mice. We see there was a decrease in the ability for them to form tumors in the mice and increased survival of the mice. And when we removed the tumors from the mice, and look, remove the tumors, and instead of putting the tumors in the mice, we also did neurosphere assays, and you can see on the bar graph that the cells treated for 20 days with DFMO were not able to form as many neurospheres as the untreated. And then in another, really kind of looking at how we would do the clinical trial, we gave the minimal disease to the mice, injecting small numbers of neuroblastoma cells into the mice, and then put either regular water or water with 2% DFMO in the water to give them maintenance therapy to see if we could prevent the relapse. And we can see that the mice that had DFMO in the drinking water had much fewer tumors or decrease in the relapse rate in those mice, and improvement in event-free survival as well. And these were statistically significant. And so our phase 2 clinical trial really was similar to this. Patients who were completed upfront treatment, so they received their chemo, surgery, transplant, radiation, antibody, and CIS-RA, and then if they remained in remission or without any progression of disease, were able to enroll on DFMO to receive for 2 years. This is one of our little girls getting her first dose of DFMO. Our primary objective was the phase 2 was to improve event-free survival or decrease the relapse rate, and secondary was to improve overall survival. And again, just a reminder, so we were starting our study at the time since end of immunotherapy. So after the gray bar, that was the point in time where patients were enrolling on DFMO. So this was our historical control. We looked at that time point and out 2 years as about a 30% decrease so our benchmark for us was 70%. We wanted to see if we could do better than that. And when we published our first results of our study, we were able to show that the patients at 2 years had an 85% event-free survival rate, and that really maintained close to 4 years survival at 83%. One of the questions that many of the patients ask is, can we continue beyond 2 years? Is it necessary to continue beyond 2 years? If we stop at 2 years, will the patients start to relapse? And really this showed us that, as you know, the relapses do happen within the first 2 years, but the patients that make it to 2 years, we've had very few relapses after that, although there have been some. We don't believe that the benefit of continuing DFMO beyond 2 years is necessary. One of the other important questions, because this does decrease McN, is this only for McN amplified patients? And then on the side of the curve, we saw that both McN and non-McN amplified patients do equally as well once they, if they receive DFMO. And what was interesting is both do have an improvement in their event-free survival, which I'll show a little bit more later. On the overall survival, we saw 97% of our patients still alive at 2 years and 95% at 5 years. This was the biggest improvement based on historical control estimate that we could have. Again, that was an estimate. So when we met with the FDA at this time point, that was the most compelling evidence that if we're able to have so many more children alive than not, we needed to look at this further. And they asked us to look at it in 2 different ways to identify the best historical control. So could we find a fit for purpose external control? What we found though was that 81 out of our 100 patients actually had come directly from the AMBL0032 clinical trial and then enrolled on DFMO. So they had come directly from that study onto our study and received DFMO. So could we look at the rest of that patient population, the same patient population that were on AMBL0032 that did not receive DFMO? And so we were able to obtain the raw data for that study from COG. And then so as you can see here, we had 852 patients that did not receive DFMO. When we looked at the selection rules, they do result in similar populations. There were, McN amplified status was very similar, stage 4, very similar. So very similar patients. And so when we looked at the entire population of the those that did not. And these are only patients that were on AMBL 032 that could have enrolled on our study. So they had to meet all the criteria to also enroll in study in regards to no progression of disease or anything like that during the study. And we saw a significant difference in event-free and overall survival at 4 years. Our event-free survival 84% versus 72%, as we had anticipated, that were on DFMO. And the overall survival was 96% versus 84%. Again, that's 12% of children alive that would not have been alive. And we also present the FDA with the safety data for DFMO. So in general, DFMO is an oral pill taken twice a day. The main toxicity that we follow really is hearing loss. This is about 10% of patients, as you can see here. The hearing loss is a reversible hearing loss. It's an interesting, it occurs in all speech ranges, which is why it's so important to follow, as opposed to cisplatin hearing loss, which is really in the high frequencies. This really occurs even in the speech ranges. It's kind of the whole curve kind of just goes straight down. We do follow it once there's a 20 decibel decrease below normal. We do hold the DFMO, allow it to reverse, and then decrease the dose. It's a dose-dependent hearing loss. And so it's one that we want to see a reverse to baseline and then decrease the dose to restart. All patients have been able to complete the DFMO. We just need to watch that very carefully. We do see ear infections, but in general, it's been over a 2-year time period of children that are, 3 to 10 years of age. If they're going to get ear infections, we don't think that's really related to the DFMO. I think it's normal childhood. Same with the pneumonia, diarrhea. We report everything that occurs with patients on the DFMO. The ALT-AST decrease may be related to the DFMO. That has some temporal relationship, but does decrease on its own. So it's not been to a degree where we need to hold the DFMO. And then the decrease in hemoglobin we have seen. So we have a study for medulloblastoma where we treat at a higher dose, 2,500 milligrams per meter squared, to get into the CNS, because DFMO crosses the CNS at about 25%. With that higher dose of DFMO, we have seen a decrease in hemoglobin, even as low as 6. So that requires transfusion and then lowering of the dose. Again, it's a dose-dependent side effect. And so it does respond to a decrease in dose. At the doses we're using currently for neuroblastoma, we have not seen that decrease in hemoglobin, but at the higher doses, we do for the CNS. So in many discussions with the FDA, we determined that to further use this data for FDA approval, we needed to do propensity score matching. While we looked at the entire population, we see a significant increase. Propensity score matching is allowing us to take one of our patients and match it to a patient in the larger database based on all of the risk variables, so we can find a like patient. And we actually decided with the FDA to do a 3-to-1 match. So for every one of our patients, we needed to find 3 patients within the database of 800 patients that would match that patient identically for all risk variables. Propensity score matching reduces bias when comparing patient data from different sources. It matches individuals based on propensity score match to optimize the similarity of the two groups, and it balances the covariates between the treated and control groups, and also reduces confounding differences to better isolate the treatment effect. It's been used in many other adult studies. This is the first time we had used propensity score matching. We had a lot of discussion with the FDA with what are the variables we needed to match on, and between our group and the FDA group, these were the 11 variables based on age of diagnosis, response at the end of immunotherapy, pre-transplant response without bone marrow, sex, age, stage of diagnosis, the time from transplant to start of immunotherapy, because we know delaying time can sometimes affect outcome, the time from diagnosis to end of immunotherapy. Again, was there a reason that patients were requiring extra treatments, time of start to end of immunotherapy? Did they have breaks in treatment? The type of transplant, single or tandem. And then MICN was the one cofactor that was required to be matched exactly for each of the patients. The others were based on a score. So for a patient that potentially that has MEK amplified with a score of 8.2, we had to find patients that match that score as well. And so in doing the propensity score match, we're able to see that the covariates, the population characteristics improved significantly. They're almost exact now in terms of all of the covariates, really 1 or 2% difference in each of them. And this is kind of looking at all of the different covariates in even more than the variables that we initially had shown. Without the matching, you can see the green. With matching, they're all within 0.1 standard differential from each other. So the patients are very well matched at this point. And we can see that even with the propensity score matching, we had to determine the statistical analysis plan of the propensity score matching before the statisticians could look at the data at all, so that there would be no bias whatsoever. Once all of the statistical analysis plan was done, the variables were agreed upon, the method for the analysis would be done, then the FDA statisticians as well as our statisticians did the analysis separately and then compared. Everyone came up with the same results and showed that the propensity score confirmed the increase in event-free survival, again, from 84% at 4 years still in remission versus 73% without DFMO. And the overall survival difference was, again, very significant, especially since after the 5 years, our line stays pretty straight across, whereas the COG, his standard of care line still continues to decrease survival, really down to less than 70% survival, where ours stays up at the 96. This is a summary of all of the different DFMO analyses that have been done. Again, we did compare the first graph I showed you was our analysis in 2018 of just the standard results. We did do an analysis in 2020. That was the first analysis the FDA had asked. That was a comparison of the DFMO treated patient compared to neuroblastoma patients treated at our hospital, as the same 20 hospitals that participated in the study, without DFMO, our historical control from our experience without DFMO to our experience with DFMO. We did do, and again, it showed very similar, 82% at 5 years, 85% event-free survival versus 65% event-free survival, and the 5-year overall survival was 95% alive versus 81%. What was interesting, we looked at the sub-analysis of MEK amplified versus non-amplified versus amplified. We do see an improvement in both. So the event-free survival 5 years for MEK non-amplified patients was 80% versus 97%. This is backwards. That one's backwards. And then versus 91% and 75%. Sorry. So this is really helpful because we do get a lot of questions. Does MEK amplification matter? Should it only be MEK amplified patients? But we do see, again, 97% versus 85%. That's backwards. And then 75% versus 91% still in remission. This is interesting. But the overall survival, let's just go to that. Something's wrong with my event-free survival numbers there. But 92% alive versus 88% and 97% alive versus 78%. So while the difference isn't as much, it is still significant. And these are the ones that we just went over. This is the 2023 analysis, was the propensity score match. So after looking at all that, discussing with the FDA, could we do a randomized trial? Was it still ethical? And even the FDA and our teams agreed that given the over 12% to 20% increase in overall survival, children alive versus dead, it was no longer ethical at that point to do a randomized trial. And the FDA framework did allow for regulatory approval in rare diseases with single-arm studies. The availability of the AMBL 0032 data really is what made this possible. The patients had come from that study and then were able to have all of the raw data. So in November 2022, a new drug application was submitted to the FDA. The FDA required an ODAC meeting, which is Oncology Drug Advisory Committee meeting, on October 4th of 2023, because this was the first time that the FDA would potentially approve a drug in oncology with a single-arm study. So the FDA was a day-long meeting they brought in an external panel of 20 oncologists, statisticians, epidemiologists to evaluate the process, looking, was this an appropriate external control? Was there an assessment, an adequate, well-controlled study? Was this an inadequate and well-controlled study? Was there substantial evidence? So they are allowed a single-arm trial with confirmatory evidence. So all of the preclinical mouse work, lab work that I showed before was all a very important part of the drug approval process. And was there an overall risk-benefit assessment for the patients? Was it in terms of safety? Was discussed there. They looked at many more sensitivity analyses, and basically, if it's on this side, on the left side of the curve, the sensitivity analysis favored DFMO, and you can see every sensitivity analysis that was done favored DFMO. And during the FDA meeting, it's very interesting. There was a 1 hour during the middle of the day where advocates and parents were able to call in a public forum, because the FDA reports to the public here. And there was it was an hour full of testimony from families and parents and advocates on the benefit of DFMO. And it was incredibly moving, and I think did help move this drug forward. Then the 10 minutes of the voting committee in progress, and there was a 70% yes. Again, there was still some adult oncologists and statisticians that did not like the fact that it wasn't a randomized study as expected, but the overall vote was yes. And that was the first time, again, that landmark decision for the FDA to rely on a single arm study to support a potential approval in oncology. Because that's a recommendation, the FDA doesn't need to necessarily follow it, but they did approve iwilfin on December 13th of 2023. So the drug is called iwilfin in honor of Will, who was the patient from the phase 1 clinical trial, who's actually now in college today. This was him at 11. And then Finn, who was actually the nephew of the VP from the company, because as we all know, neuroblastoma or pediatric oncology is not a significant moneymaker for a pharmaceutical company, and they don't often invest in pediatric oncology, but the vice president of this company, her nephew Finn, has actually ALK-mutated neuroblastoma. So he was treated with DFMO with an ALK inhibitor and is doing well today. So then it was named after these two children, and so the medication is now called iwilfin. So just in conclusion, DFMO is a cytostatic and targets cancer stem cells to inhibit tumor formation, both in vitro and in vivo models. And again, the models were critical for approval, but DFMO is shown to prevent relapse and increase survival in children with neuroblastoma. We do have additional clinical trials available going on, and we're continuing to study this further in neuroblastoma. We do have our NMTRC-006 study is our expanded access, and this is really now become really mostly for international patients, because in the US, everyone now is able to access the DFMO through prescription, but it is available now in Australia, Israel, and the UK. So there are other countries where DFMO approvals are happening, where our research and the company is also, not my company, the company is also helping to make this available in many, many countries. So hopefully it will be available elsewhere. But until that time, because it is expensive in other countries, it is available on the expanded access program through us. And it's really for Lin28 MYC and tumors. So we do have other patients, not only neuroblastomas, ETMR, ATRT, other rare tumors are enrolling on this study as well. And we did have Wilms tumor with MYC amplification that did incredibly well on this as well. We do have our NMTRC-001 that this has completed study. That was our other maintenance study, and it's completed enrollment. And then our 012, because we see that 14% of patients still relapse during immunotherapy, our question was, could we bring this up and give it during immunotherapy to prevent relapse? The FDA did ask us to do a randomized clinical trial, even though they did approve the drug. So we do have a randomized study for patients at the beginning of immunotherapy, either receiving DFMO during immunotherapy or not. At the end of immunotherapy, though, everybody gets DFMO for 2 years. And so that is continuing to enroll, but because it's a randomized study, it's 200 patients per arm, will take quite a long time to complete that trial. We do have, for patients who have relapsed refractory disease with oral etoposide, similar to our phase 1 study, that study is continuing to enroll as well. And then for medulloblastoma, the high risk, ultra high risk medulloblastoma patients with MYC in those. That's available for at the end of medulloblastoma treatment, can enroll on that study as well. I wanted to share also the patients our experience so far with patients from India. So we have 10 patients currently or completed receiving treatment with DFMO that came to us from your country. These are the patient IDs. Most of them are on the 014 study, maintenance study. We have one in the relapsed refractory study and one on the expanded access study that came to. These are just the patients that came to us who were in remission. Just kind of what the patients received. Some of the patients did receive extra chemotherapy, but generally chemosurgery. Some did need, as I said, additional chemotherapy. Many did not. This one patient, it's really interesting that did induction chemotherapy, still had a curie of 7, did salvage with TVD, came down to a curie of 1, did go on to transplant with a curie of 1. But that is the one patient that did relapse within 6 months. All the others continue to remain in remission. Some of these have completed and are off DFMO for some time. Some of these more recent ones here are still on DFMO and continuing to come back and forth between us. But so far the data looks pretty encouraging that most of these patients are continuing to do well so far. So that's great. And that is the end of my talk. And again, I'm so thankful to all the patients and families who participate in the research and make this possible so that we can learn and help more kids and advance our treatments. And I will stop there. I'm happy to take any questions.
Thank you, Paula, for sharing your remarkable journey of DFMO. It's really impressive and a lot of learning points over there. So there are certain questions in the chat box. Before that, I would like to take my question. What challenges do you foresee in integrating DFMO in the standard protocol treatments for neuroblastoma?
Yeah, so here it's now actually even the COG is starting to in the new clinical trial has incorporated DFMO as standard of care for maintenance therapy. So I think bringing it into maintenance therapy is now becoming accepted across this country. Thankfully, I think the biggest challenges right now is getting it into all of the other countries. We're working with a lot of the regulatory agencies and trying to answer all of the questions from each of the different countries, some requiring randomized trials, et cetera. And so making sure that we can make the drug available so that those trials can happen in all of the different countries so that the patients there can benefit and not, only those that can travel can have DFMO. We want to make it available to all the patients, even those that aren't able to travel. I do want to bring it up earlier in treatment. It's very well tolerated. There is some research in DFMO that alters the tumor microenvironment and increases the immune cells within the microenvironment. So I think that having it with the immunotherapy is very reasonable, and this trial is just going to take so long to complete because randomized study in such a rare population, with 200 patients per arm is going to take us years and years to do. It's just a challenge that we have to do it as a randomized study, but we do. So those, it's the push and pull. We want to be scientifically rigorous, yet at the same time, we want to move the field forward in less than 10 to 15 years. And that's the challenge.
So one question from one of the delegate. They are asking that the patients which you have included in the DFMO trial, they had a baseline event-free survival of almost 70%. So all these patients had received immunotherapy and then they have been taken in your trial, or what could be the reason for such high event-free survival? And because we don't see such good event-free survival in our patients in India.
Yeah, that's really the 4-year event-free survival. When you keep going on that curve, it, as I showed at the end, it does continue to decrease. It's really closer to 60% by the 5-6 years. Early on, it's the 70%, but without DFMO, the curve continues to decrease.
And so in your experience, when you're treating so many patients, as per your experience, what do you think, which patients will be most benefited? Definitely the drug is expensive. Not all the patients can come over there. So if we have to advise some of our patients, one is that, can they get drug through expanded access? And second, which other patient population will be most benefited by this drug?
Yeah. Yes, they can definitely come and have access on expanded access. Looking at that, really the patients who are Curie score 0 going into transplant are the patients that will have the better outcomes. And those are the patients that we definitely see do better long term. So I think getting the patients into a Curie score of 0, and there's recent COG publication as well, show that's the same thing, that Curie score of 0 is probably the most important thing. But I would say, the patients who are McKin amplified are definitely the ones also that I would give a higher preference to. They're the ones that probably need the medication the most. But if they're close to in remission or at least PET negative by the end of induction therapy, what's interesting is of the 100 patients on our first study, 16 of them actually still had MIBG positivity at the end of induction, because sometimes there's a little bit of tumor remaining, or for those patients, we did a PET scan, and they were all PET negative. So that we allowed them to enroll on DFMO. All of those patients actually are 100% of those are still in remission today. We looked at that small subpopulation. So just because they're making MIBG positive at the end, if they're PET negative, I would still put them on DFMO.
Great. So another question by Dr. Guru Prasad is what is the cost of DFMO in US out of clinical trial?
I believe it's expensive. It's about 13 to 15,000 per month.
Okay.
Yeah. And I don't know, when I was going through also relapsed refractory patients who are able to get back in remission, I didn't highlight those patients. One of the India patients at the bottom, the one that's on O15, is actually almost completed, is a patient that, I was going to look at, that was a patient that did relapse, completed the standard treatment, relapsed about 6 months after, in February of 2022, then got maintenance metronomic chemotherapy, radiation to the spot of relapse, and further anti-GD2 therapy. And that patient's been on DFMO for a year now and remains in remission. And so we do see for relapse refractory patients that can get back into remission, our event-free survival curve is over 50% stay in remission long-term, and the overall survival is over 60%. So while historically for us, often relapse refractory patients are not curable, we are seeing that 50% of them are curable. So if they're able to get back into remission, those are probably the highest risk patients. And I think trying DFMO is definitely worth it for those patients.
Great. Thank you. I think we have less time now, only 15 to 20 minutes left. So we'll go for the panel discussion. Please be with us for this panel discussion as well. Thank you so much.
Yes, definitely. Thank you.
Dr. Anaga from our hospital, clinical
Hello.
associate, she'll be taking
Good
over
evening,
with the
ma'am.
panel discussion. Yeah.
Yeah, good evening, everyone. So I'll just be sharing my screen. We'll be starting the panel discussion. So Dr. Giselle, it was a lovely talk. And we've seen your dedication and everything. And of course, we'd love to have greater outcomes for neuroblastoma as well. So going on to panel discussion, how to improve neuroblastoma outcomes. I am the moderator, Dr. Anaga Kulkarni. I'm working at Sir H.N. Reliance Foundation with our director, Dr. Shweta Bansal. Introducing the panelists, we have Dr. Benita Rajeshwari, who's an associate professor in the Department of Pediatric Oncology at Regional Cancer Center, Trivandrum, Kerala. Dr. Manas Kalra, sir needs no introduction. Also, heartiest congratulations for the award for the PHO chapter in Pedicon, sir. He's a senior consultant at Sir Gangaram Hospital in Delhi and the honorary secretary of our PHO chapter of Indian Academy of Pediatrics. Next, we have Dr. Shivani Patel, who's a consultant pediatric hematology and oncology at Chaitram Hospital and Research Center in Indore. So let's go on with our panel discussion. It will be a case-based discussion, which we'll try to run through quickly. So the first case was a 3-year-old girl who presented with abdominal pain and distension. for 25 days, and a CT showed that there was a large multi-compartmental abdominothoracic lesion with multiple lymph nodal involvement and intraspinal extension as well. On further evaluation, PET confirmed that they were metabolically active lesions involving the abdomen, paravertebral soft tissue, encasing a lot of vessels, and multiple marrow lesions as well. Bone marrow was also positive, suggestive of a round blue cell tumor showing metastatic neuroblastoma, which was confirmed by the retroperitoneal mass biopsy. So she was diagnosed as a high-risk neuroblastoma with unfavorable histology, non-infantile stage M with bone marrow involved, and NMIC was amplified. So she was started on chemotherapy with rapid Kojak as per standard guidelines. However, unfortunately, on response evaluation, her bone marrow was positive. So my question to Dr. Benita, how would you proceed further in this particular scenario?
Hello, good evening all. I hope I'm audible. Am I?
Yes, ma'am.
Yeah, thank you. So here we have a neuroblastoma, high-risk neuroblastoma who's metastatic to start off with and has received chemotherapy with a rapid Kojak, 8 cycles of chemotherapy. But unfortunately, at the end of the rapid Kojak chemotherapy, the child continues to be bone marrow positive. So ideally for the patient to proceed on to the next phase of chemotherapy, to proceed with surgery as well as with stem cell transplantation, the bone marrow needs to be in remission, especially once the Cyopin criteria, which the Cyopin group who uses a rapid Kojak, for the criteria, the bone marrow needs to be negative. So how do we proceed further? Maybe we can try a second line of chemotherapy here. The recommended second line is usually topotecan, vincristine, and doxorubicin. So we can try around 2 to 4 cycles of TVD chemotherapy for this patient and then reassess the bone marrow. So what we would expect with TVD is that at least around 40% of patients will be able to attain a remission, either at least a partial, a better than partial remission, a partial or a complete remission, and bone marrow becomes negative, and they will be able to proceed on to further stem cell transplantation. But the main toxicities of concern here would be hematological toxicities and stomatitis. Otherwise, the TVD chemotherapy is usually well tolerated, and you would expect to get a good response with the chemotherapy. So you proceed with 2 to 4 cycles of TVD.
Right. Thank you, ma'am, for your answer. So as shown here, TVD protocol is recommended, and it has shown that it has been effective in improving response rates of high-risk neuroblastomas who are positive post-induction. So as per that, she was given 2 cycles of chemotherapy. However, post 2 cycles as well, the bone marrow was still persistently positive. As seen in this report, there was a response, but there was still a less than 1% residual metastatic tumor deposit in the tissue submitted from the left-sided biopsy, previously which showed 6 to 8% of metastatic cells in the tissue. So my question to Dr. Manas would be, how would you proceed further in this scenario where she's already positive post 2 cycles of TVD?
See, it's quite a desperate situation now because you have used the most active agents for neuroblastoma already in this kind of a scenario. You are hardly left with drugs that are very active during the initial phase. Now, there are many trials where they are using immunotherapy upfront for such patients and trying to explore whether immunotherapy works. But in our scenario, in such a situation, we generally continue with the chemotherapy agents that we have, and we are not able to really introduce many newer drugs at this point of time. So, we may want to give 1 or 2 more cycles of chemotherapy agents that we have already used. The issue here, and I want to ask this question, is about the harvesting of stem cells for bone marrow transplant. Because that too also, after giving so much of TVD cycles becomes very difficult, and you are not able to get a good harvest to do an autologous transplant. So that becomes a big challenge. And with this micrometastatic disease, I don't know whether that really would matter, whether, we should really harvest the stem cells and keep, because purging or no purging also did not really differ in the outcomes of these patients. So I would, probably go ahead, do a surgery, think of more chemotherapy. Autologous stem cell transplant should probably clear all the residual disease, followed by immunotherapy that we will use. So, it may be very difficult to actually clear this. You may want to consider doing the surgery, going ahead and doing a transplant, and that may help to clear the marrow disease. And I would appreciate everyone else's opinion also in this situation. One, as to timing for the stem cell harvest, and number two, can we just proceed and hope that the BMT immunotherapy will clear this?
Yeah. No, so we highlighted this point over here, Manas, just because of this reason, as you have said that this is a desperate condition at this point. And the only thing over here I would like to highlight is that our pathologist was telling this patient is still positive, still positive. So we went over there to the department, pathology department, and we asked them exactly tell us what percentage of the cells are still positive, and gave us the answer that it is less than 1%, but it is still there. So it shows that there is some response, but definitely complete response is not there. And this is the paper we found actually, which we shared with our pathologist also.
So these were the recommendations for bone marrow reporting status, which showed that if it was less than or equal to 5% or tumor infiltration was there, or if there was no tumor infiltration less than 5% on reassessment, or if it was more than 20% tumor infiltration that has 0 to 5% tumor infiltration on reassessment, then it could be taken as just a minimal disease, or a bone marrow with tumor infiltration that remains positive with more than 5% on reassessment does not meet criteria for complete response, minimal disease, or progressive disease would be a stable disease. So considering this, our patient was fitting into these criteria, so we decided to treat her further. So there are Dr. Giselle, would you like to give your opinion on this, ma'am?
Sure. Yeah. Here, I mean, here in the United States, I would move to surgery actually soon as well. And then this is minimal disease. So some oncologists here would go directly to transplant because with that small minimal disease in the marrow, it's likely to cure. Others really are trying to now move towards complete remission. And so irinotecan tamitar is our standard that would, and if possible, irinotecan tamitar antibody is really the standard that occurs now. And in our protocols, it would be irinotecan tamitar antibody. It would be the treatment prior to transplant, hoping to remove that residual disease, especially if it's bone marrow or bone, the antibody is more likely. We're actually using in our Beat Childhood Cancer Consortium, we're using naxitamab prior to transplant. Our upfront treatment actually incorporates naxitamab with all of induction chemotherapy. So, and then dinutuximab after, so the patients have the opportunity to receive both antibodies because each responds a little bit differently. But irinotecan tamitar would be the medications we lean towards.
Thank you, ma'am, for your wonderful answer. So, so for this patient, we actually went ahead with certain chemotherapy, and these are the various drugs used in refractory neuroblastoma in various combinations as per the various collaborative groups. So we went ahead to give her 2 cycles of temozolomide with irinotecan. However, unfortunately, still after that on evaluation, she was positive. So we went ahead and gave her 2 more cycles, after which she was finally in remission, complete remission with pertaining to the bone marrow. So after this, we went ahead to do a surgical resection post this extensive chemotherapy. She had a little complicated anastomy course post-surgery with intestinal obstructions and adhesions with some chyle leak, for which she needed an exploratory laparotomy. However, she was stabilized post that. After this, as per protocol, she went ahead with an autologous transplant with the conditioning of busulfan and melphalan, followed by radiation given to the primary site. So I would like to ask Dr. Shivani, in such kind of a disease which is micrometastatic positive despite multiple chemotherapies, is there a role of ASCT versus a haplotransplant, considering this slow response to chemotherapy?
So this is kind of a refractory disease. It is a difficult situation. So there has been some data where people have tried using immunotherapy in the form of allo transplant in neuroblastomas, but there is where they have used melphalan-based reduced toxicity conditioning. But having said that, the data is not very promising, or there is feasibility or tolerability data, but whether that actually improves outcome is yet to be answered. So I personally do not have experience of an haplotransplant in such situation, and I would probably go ahead with the standard autologous transplant followed by immunotherapy if the patient can afford.
Right.
And I
Thank you,
think
Dr.
most of the data is also TCR alpha beta depleted transplants, so they are not the usual ones. So you need to understand the implications of doing that kind of a transplant for your patient.
Right. So, Dr. Giselle, would you have you had any experience with any haplotransplants in such sort of a scenario?
We have not done haplotransplant here. We would
Right.
move directly to the BML. Yeah.
Right.
So it's generally, I think, German data, which is
Because-
in haploidentical transplants followed by immunotherapy.
Right. So in this particular situation, considering we've already done an autologous transplant with radiation, what would be the next step? Like immunotherapy, as we know, has good outcomes. So Dr. Manas, how would you proceed in this case?
So definitely high risk neuroblastomas, we would recommend using immunotherapy for these patients. Again, the big problem for us is the cost availability of the drug. It has to be imported. It is not covered in insurance. The patient has to pay out of pocket, or you have to do, crowdfunding for that. So those are the big challenges for us. But yes, that would be the next step for these patients.
Right. Also, lastly, Dr. Giselle, I know you've already said this, but just your experience regarding the use of immunotherapy upfront as a part of chemoimmunotherapy in a newly diagnosed neuroblastoma.
Yeah, absolutely. Since the AMBL-032 study with the dinutuximab showed that increase about 10% in event-free survival, it's become standard of care in the United States here, as everyone will receive the immunotherapy with the RA.
Right. So these studies, the phase 2 trial of HU1418 in combination with induction chemotherapy in children with newly diagnosed neuroblastoma also states that adding it to induction chemotherapy produced early remission or better response in most patients. So there are various trials which are intensifying therapies of high-risk neuroblastoma, which are ongoing, and like ma'am has showed, there are a lot of DFMO trials as well. So going ahead with the further course for this patient, she went ahead with 6 cycles of immunotherapy with anti-GD2 antibody as per the protocol. She was also enrolled for the DFMO clinical trial and was given for 2 years. This is just a table showing the VMA levels of this patient, which were serially falling on DFMO therapy. And now currently she's 1 year post DFMO treatment and in remission. So definitely, ma'am, we've seen that DFMO has helped in this particular patient. So this was about the first case. Quickly going on to the second case, we'll rush through it in view short of time. So this was again a 3-year-old child who presented with body ache, fever, and some right-sided hemiparesis with trembling when the child tried to hold some objects. An MRI brain and angio was done, which was supposedly normal, developed some difficulty walking and loss of balance, and was diagnosed as an opsoclonus myoclonus ataxia syndrome. He was given IVIG for the same and discharged. However, fever persisted and he was diagnosed to have a lower respiratory tract infection with significant lymphadenopathy. A COX workup, TB workup was negative, and a CT scan of the chest was done along with a lymph node biopsy. The CT showed that there were multiple lymph nodal masses in the mediastinum, quite large, with multiple masses in the upper abdomen as well. So a biopsy from the same showed a metastatic small round cell tumor with which was claimed as a metastatic neuroblastoma, which was undifferentiated. So after this particular episode, he was seen with us for further treatment. So he was a child with lesions in the thoracic and the suprarenal region, histopathology showing undifferentiated neuroblastoma. Baseline labs were showing that LDH was 845 with a ferritin of 200 and urinary VMA levels were 98. So we went ahead and did the metastatic workup for this child, which showed that the bone marrow was involved. A retroperitoneal mass biopsy confirmed the diagnosis, and it was a neuroblastic tumor suggestive of neuroblastoma undifferentiated. So the PET scan, as you can see in these images, showed a large conglomerated lymph nodal mass in the chest as well as the abdominal region. An MIBG scan was planned but could not be done due to some logistic issues. So the final diagnosis was that he was a high-risk metastatic neuroblastoma with primary in the left suprarenal region with a metastatic disease to the thoracic region and the bone marrow. So he was started on rapid Kojak, and post-treatment, you can see there is some reduction in the size of the lymph nodal mass as seen on X-ray. He tolerated the chemotherapy well, and a response PET was done. So the response PET, from the images, you can see that there is a significant reduction seen. However, there was still a persistent size of lymph nodes present in most of the metastatic sites, including the primary site. So post-Kojak, when he was evaluated, the primary disease showed a very good partial response. However, his bone marrow was still persistently positive. So as discussed previously, he was also given 2 cycles of TVD chemotherapy and then evaluated again. So a CT showed significant decrease in the primary lesion, the bone marrow was uninvolved, and the child underwent a surgical resection. So this is the background of the entire case. So what would be our next plan of action, Dr. Manas?
So again, this is a high-risk neuroblastoma. Both your cases actually did not have bony metastasis, and those are really the bad players. And I would like Giselle's comment on, whether the children with bony metastasis, extensive bony metastasis did, how did they fare as compared to the ones without bony mets in their DFMO trial? That would be something that I would like to know. But yes, we would proceed. You have done all the initial steps, and the next step would be to do an autologous transplant, to give radiation, and to do immunotherapy for this patient.
Correct, sir. So considering this particular case, is there a role of any MIBG therapy with thiotepa versus a local radiation at maybe multiple sites, since the disease is persistent at different sites?
So did you say that this patient is now PET negative?
So he is not completely PET negative. There is a very good partial response, but there is a metabolic lesion.
So you may want to consider, initially it would be, doing an autologous stem cell transplant and then reassessing. The role of radiation to the metastatic sites is a question that is often asked. There is benefit of giving radiation to the metastatic sites if they are active, but if they are inactive, I'm not sure if the radiation to the metastatic sites would be beneficial. So that is what usually we follow. We would give radiation to the primary site. So our next step would be an autologous transplant and then giving radiation. We do not use MIBG therapy upfront. It is mainly referral based, only for patients who have relapsed refractory disease. And at our center, we are not doing MIBG therapy.
Right. Dr. Benita, would you have any inputs to give in this particular case?
I think I'll agree with Dr. Manas. Like even in our centers, MIBG therapy is not available as such. So we would be proceeding with autologous transplant and followed by immunotherapy, that is the off-plan.
Right. Thank you, ma'am. So we had a debate in our center regarding this MIBG therapy with versus local radiation. So there has been no head-to-head trial comparing the two as such. So it's a very difficult question to answer. However, MIBG therapy still would be very difficult in this particular scenario. So we would also probably plan an autologous transplant for this child. Now, there are certain trials which show that after the chemotherapy, you could randomize patients to MIBG, topotecan, high-dose thiotepa, and then stem cell collection, followed by another high-dose chemotherapy with Bumel and another transplant. So the Veritas trial is ongoing, and the results I believe are not yet out fully. So Dr. Giselle, would you have any opinion on this, ma'am?
Yes. So COG had incorporated MIBG with Bumel in one arm of the 5-arm study, but that arm closed due to toxicity. There's significant toxicity in combining the MIBG with Bumel, and so that arm is actually closed now. So I would hesitate to do that. We would not, our center would not recommend MIBG therapy at this point. We've just seen too long delays after MIBG treatment to be able to get to the next therapy, and toxicities that, it's really important for these children to stay on therapy and to be able to continue to receive therapy. But there's really an 8-week period after, and if there's any residual disease, the disease can start to grow back while you're waiting for recovery. It's a challenge with the MIBG up front. So we would recommend more the transplant to be able to stay on top of the patient.
Right. Thank you, ma'am. So that was about the second case. Now proceeding to the third case, again a 3-year-old child who presented with abdominal pain, fever, and some constipation, had a lesion around the left kidney. A CT scan showed that it was a mass lesion with calcifications. PET scan revealed that it was a metabolically active lesion on the left side of the abdomen. A bone marrow was uninvolved, LDH was 280, ferritin 90. A biopsy confirmed that it was a poorly differentiated neuroblastoma of unfavorable histology. Rushing through quickly because we are a little short of time. The MLPA testing was done for this patient, which showed an NMIC amplified. ALK was also amplified, which is a thing to be noted in this particular case. So he was a high-risk non-infantile neuroblastoma with the left suprarenal primary with unfavorable histology. L2 disease, non-metastatic, bone marrow uninvolved, but an NMIC amplified disease. So he was treated as per standard protocol with chemotherapy with rapid Kojak. The response PET scan was good. Then he underwent a left adrenal neuroblastoma excision, which was good, followed by consolidation with an autologous transplant. The histopathology showed a residual viable neuroblastoma with good excision, and the child underwent local therapy with radiation, which he tolerated very well, and then he was started on oral retinoic acid as per treatment. Unfortunately, 2 months post the transplant, he presented with an acute abdominal pain and mass in the left lumbar region, and he was diagnosed as a relapse within 2 months of completion of the transplant while he was on retinoic acid. So my question would be to Dr. Shivani, is there any role of further treatment, or would you consider offering palliation to this child?
So a high-risk neuroblastoma, very early relapse post autologous transplant, probably in our center, I would offer palliation because no matter whatever the therapy is, the outcomes are still very, very poor in this child.
Right. Unfortunately, because of monetary concerns, the child could not get immunotherapy, but is there any role of ALK inhibitors in this particular case? Dr. Benita, would you like to take that question?
I have actually no experience on ALK inhibitors in neuroblastoma. I can only actually quote from the literature. On a practical front, this patient would absolutely be palliation for us because it's a very unfavorable biology. Both the NMIC and ALK amplification are there. Just even in our experience, we recently had 2 patients who had expression of both NMIC as well as ALK and had very, very poor prognosis. So it's a very unfavorable biology. And in our setting, where with cost factors, the availability of ALK inhibitors, everything is a major concern. I think it will all be palliation. But if you look at literature, maybe ALK inhibitors like lorlatinib may have a role, but I'm not very sure about this. So
Right.
this actually the phase 1 trial results from the group that has actually shown that in children less than 18 years of age with lorlatinib as a single agent, the activity is not so good. But in less than 18 years, if it is co-expressed if it is given along with chemotherapy, it does have a role. Maybe because it acts on the NMIC expression as well. It's all theory from him. Sorry. Maybe Dr. Giselle might be able to contribute better to that question.
No, this definitely is a difficult situation. My only concern in this case was that this child, to start with, it was a non-metastatic L2 disease, and it was a local disease which we treated with bone marrow transplant as well as radiation. So this patient even has received radiation, and within a 1.5 months of receiving radiation, he had a local recurrence at the same point. So our concern was that whether we should do a palliation only or whether we should give certain more therapy followed by another surgery and then think of ALK inhibitors in this case. Dr. Giselle, what are your thoughts in managing this case? How would you like to manage it? This patient comes to you.
Yeah, what is the size of the tumor, and is it possibly resectable at this point?
So the size of the tumor was 4 by 3 centimeters. So it was this thing, but it is encasing the major vessels still, and the surgeon was not very keen on doing a surgery because already the previous surgery has been done like 3 months
Yeah.
back.
Yeah, and the radiation was to that area as well, because that's the other that we would definitely recommend the radiation. If it's possible to do needle biopsy and then we would send for the genomic sequencing to do a molecular tumor board to look for other targets. But we would probably give the ALK inhibitor, the lorlatinib, in combination with irinotecan temodar, and then if you had the opportunity to do immunotherapy, would treat with that as well. But at least the ALK inhibitor with irinotecan temodar, and then followed, if that is able to induce a response, then I would add DFMO for the McN portion of this tumor. We have a cohort of over 10 patients that we've treated with McN and lorlatinib, or an ALK inhibitor, that we're actually putting the data together to present at SIOP this year, because that is such a high risk group of patients with that combination of the McN and ALK amplification. But we have a group of patients that have done very well with the lorlatinib DFMO. But I would start with irinotecan temodar and a lorlatinib and see if they're able to induce a response, then add the DFMO on the expanded access program. But it's going to be a challenging case.
So,
given
when
that.
talking about the ALK inhibitors in these patients, we have a lot of literature on whether these patients are having an ALK amplification, whether they have a ALK mutations, and ALK mutation, also some specific ALK mutations which are particularly responsive to some ALK inhibitors, especially
Yes.
which is easily available in India. So do you do any further investigation in these patients before starting ALK inhibitors, or once the patient on the MLP is ALK amplified, you start them on ALK inhibitor?
Yeah, we would have put this patient on ALK inhibitor early, if possible. But the crizotinib would be a good option as well if you have access to that one instead. That would be just as.
So do we need to do any NG?
But I like to do, so we've shown that the neuroblastomas do have clonal evolution and change over time. So we do a needle biopsy at minimum to send for whole exome, whole transcriptome sequencing. So we can look at what other pathways are driving the tumor to see if there's another better combination to put with the, with what is the best drugs to combine with the ALK inhibitor. Yeah.
So just a follow-up on that question, ma'am. So as soon as we get the MLPA report, and if that shows that it's ALK amplified, do we start them upfront on ALK inhibitors, or is it like after transplant, after radiation? What would be the time point of starting the ALK inhibitors?
So we would start it upfront with upfront chemotherapy.
Okay.
More recently in the COG study with they had the ALK inhibitor with antibody post-transplant, and there were some lung toxicities. It's unclear if the lung toxicity is from the being post-transplant or the combination of ALK with immunotherapy, because we've used ALK with immunotherapy in relapse, like irinotecan temodar antibody. But during that period of immunotherapy, now we're not using the ALK inhibitors during that period, but upfront, and then afterwards with DFMO.
Right. All right. Thank you, ma'am. So we've had a lovely discussion, starting with great insights into DFMO therapy and the trials and the great results that we're having. Thank you, Dr. Giselle Scholler, for everything. If there are any questions, we'd like to take those questions now.
We'll just check if there are any further questions in chat box, and otherwise we'll.
Yeah. So, so there's a.
Okay, yeah, please.
Yeah. So there's a question by Dr. Preeti to Dr. Giselle. Do all the patients who receive DFMO, do they all receive cisretinoic acid prior? And if yes, then for how long?
So our patients receive cisretinoic acid for 6 cycles with the immunotherapy. So 5 cycles are immunotherapy and cis-RA, and then 1 just cis-RA by itself, and then they transfer over to the DFMO.
All right. The next question is that are there any long-term toxicities that you are expecting based on your current follow-up of patients on who've received DFMO?
We have not seen, and we are following our patients for 5 years off DFMO. We have not seen any new or long-term toxicities that are unexpected.
Okay.
Great. Thank you so much.
So that was a lovely discussion we've had. I was hoping that continued advancements, accessible and affordable treatments, and better outcomes in neuroblastoma keep happening. And handing over to Dr. Shweta Bansal for the closing remarks. I'd like to thank Dr. Giselle and the panelists as well from my side.
I think, Anaga, thank you so much. You did a wonderful job, and it's a wonderful discussion we had. We'll continue to have these kind of discussions to improve the patient care, especially in neuroblastoma. And definitely we have come a long way. Thanks to Dr. Giselle and many other investigators who are working tirelessly for this disease, and hopefully we'll be able to replicate this survival outcomes in India as well. Thank you so much. Thank you everybody for joining in today.